Hi, I'm Dr. Jack West. I'm Associate Clinical Professor in Medical Oncology at the City of Hope Comprehensive Cancer Center, and also the founder and president of GRACE, Global Resource for Advancing Cancer Education. I'm very happy to be joined today for an ASCO highlights presentation in the field of lung cancer with two of my friends and colleagues from other parts of the country who are lung cancer experts with some different perspectives, and we're going to go through some of the key presentations and talk about what we think this means for patients. First, I have Dr. Helena A, who is medical oncologist at Memorial Sloan Kettering Cancer Center, and Dr. David Spigel, who is Chief Scientific Officer and Director of the Lung Cancer Program at the Sarah Cannon Cancer Center in Nashville, Tennessee. Thanks, guys, for joining. Another concept that I wanted to cover that was presented at ASCO 2020 is the integration of local therapy, specifically in this case, adding radiation to systemic or whole body therapy. This in the context of EGFR mutation positive advanced non-small cell. We have seen in the last several years a few relatively small studies of metastatic non-small cell that is with limited disease, and we will often term that oligometastatic, oligo meaning few or few metastases. That's often described as up to 3 or sometimes 5 spots of disease, so not people who have a lot of disease spread throughout their body, but in patients with very limited disease, there have been some small studies that have consistently shown better outcomes if patients got a combination of whole body treatment with a good response that was then followed by either surgery or more commonly radiation to areas of residual disease. And that is used selectively in some places. I wouldn't call it a standard of care at this point. But this study comes out of China. It has 133 patients who had up to 5 spots of disease. And this is right from the time of starting treatment. It's a little different from the design in some other studies because it didn't start with the whole body therapy, wait for a good response, and then treat with radiation or surgery to just the leftover parts. This used an upfront approach of either the pill-based therapy, and of note, this was a first-generation EGFR inhibitor, not quite as potent as the later ones that we use, especially osimertinib or Tagrisso, but still effective nonetheless. So you got this pill-based therapy either alone or in combination with radiation. It's called SBRT, or stereotactic focal body radiation therapy, to all the sites of disease over just a few treatments. And then it looked at how people did. It looked at their progression-free survival, how long before there was evidence the cancer was growing in places it was already present, or in new areas, and it also looked at survival. One point to make is that there is always in these studies a winnowing from the entire pool of patients who might have been in it to a much smaller proportion. And here they started out screening 631 patients to get the 133 in the trial. It is important to note that this is always in an area where there is selection of patients. And so it's valuable to look at a randomized trial so that we aren't just looking at good results in patients who are doing well because they were eligible for the treatment. But what this study showed was a significant improvement in both progression-free and overall survival. So a 30 to 40% improvement in how long patients went before their cancer was growing, as well as how long they lived. Now, this is not a huge study, and this study did not allow patients who had brain metastases, and this was not using the first-line treatment that we would generally favor in the US with Tagrisso. But I would say that it adds to a little more evidence that there is likely to be a benefit of adding local therapy to systemic therapy, perhaps particularly in the patients who have a systemic treatment that is likely to work very well. Particularly targeted therapies for patients with a driver mutation, like EGFR, could also apply to immunotherapy or chemo and immunotherapy. But I'm interested in your thoughts as well. Helena, I know that at Memorial you've integrated local therapies for some time, so this isn't exactly new. What did you think of these data? Do you apply it very routinely or more selectively?
Yeah, I think that, as you mentioned, there are now several studies that have shown, sort of variations of this strategy. And I think kind of it is a strategy, in my opinion, that is probably underutilized, that we don't always think about. I think that there's this strategy, as you said, and then the strategy from the Gomez phase 2 study. I sort of like the strategy of consolidating with local therapy. And
so
that's
basically giving the local treatment as a chaser after getting a good response initially.
Exactly. And I think that for me, I like that for two reasons. I think one is you're going to capture more patients. We actually had a study exactly like this where we tried to find people that were oligometastatic at presentation, and they're actually quite hard to find, as you can see by sort of how the sample size of the study kind of winnowed down. And I also think that you get sort of a better sense of the natural history of the cancer, because I think if you see 4 spots in someone when they're initially diagnosed, there could be occult disease that you don't see that will blossom, if they don't have an excellent response to treatment. So I think a couple months in, getting a sense to confirm, okay, these are the only sites of disease, let's go after them after a good response. And then I think you also make more people eligible. So people that might have had slightly more areas of involvement, but if you get good and almost complete responses in some of them, you'd be able to offer this treatment to them. But I mean, I think there's been several studies now that have shown a clear progression-free survival, as well as what's more important for this technique, of course, is overall survival, because you're completely, you're purposely getting rid of target lesions. So of course you are artificially, or sort of by very nature improving progression-free survival, but right. Seeing, an overall survival benefit in a few studies now, I think is convincing enough for me to utilize this in my patients.
So, David, I'm sure you see patients with EGFR mutations or other drivers, but probably not in the same volume that I see on the West Coast or Helena Memorial. What's been your impression, you and your colleagues in Nashville, in the last few years in the wake of some of these other smaller studies, and how much or how little does this add to that?
Yeah, well, I think, we've been shifting in this direction, I think, as a field, and maybe our colleagues in breast and colorectal cancer kind of led the way, but this idea of chasing down hotspots, and of course, we all changed our care, well, for a little while, in limited stage small cell, extensive stage small cell, giving radiation after upfront chemotherapy. We didn't really understand why that would improve outcomes for patients when they had widespread disease. I use this strategy a lot, but I tend to wait. I tend to wait to be sure I'm not going to be surprised before putting someone through therapy that doesn't likely hit the main spots. And so until I'm sure where the cancer is, I don't really go after them early. I also am unsure what is too many. What is too many to go after? And I'm talking about outside the brain, because we treat everything in the brain. But, is one lesion in the lung or several in the lung or several in the liver just too many to do this with? And this study is very interesting. I think it's got a lot of faults to it, but it's still interesting. And I think we're going to be seeing ourselves doing a lot more of this even beyond lung cancer.
I agree. I also think it gets to a fundamental different concept. I was trained at a time when we were taught that metastatic is almost binary. It's like being a little pregnant or something. If you have metastatic disease, perhaps with the exception of one lesion that we called a precocious metastasis, there was not a value in giving local therapies like surgery or radiation to focus on one or two spots if the so-called horse got out the barn. Anyways, there's no point in locking the barn door after that. But this suggests that metastatic disease is more of a spectrum than a binary process, and that if you're on one end of the spectrum that is more limited, even if it's still on the metastatic spectrum, you can potentially change the pace, the trajectory of systemic disease by treating with local therapy. I think that's a kind of fundamental change. And as you say, they are seeing data to support this in prostate and breast and some other settings. So I think it's a real change in how we think about it.
The one thing that we need, and I'd be interested to know, Helena, if you guys have solved this, as we do more of this over the last decade, following people and knowing what scar or leftover effects versus progression can be troubling sometimes. And, I think technology with imaging is going to get better to help us discern what is actually viable tumor versus, scar or inflammation, because PET scanning is not good for that, or is not sufficient.
Yeah, I think exactly right. And I think as we do this for more people, or especially, I think it's relevant. I think for targeted therapy, it's easier to say you've treated the disease, but the treatment itself isn't so, toxic. So we would just continue the targeted therapy. But I think it comes into play oftentimes with immunotherapy, people who have excellent responses, and we don't know what's scar, what's residual disease, and then treating it and then deciding whether or not to continue the immunotherapy. I think that's where it seems to come into play a lot too.